Critical Access convening meeting, October the 9th. Madeline Wilson with the Hospital Association kind of gave you a little primer and introduction to the presentation that she's going to be sharing with you today, Achieving Health Equity in Your Organization and the Communities You Serve. Before we would begin, I'd like to thank Allie Orwig with the Indiana Rural Health Association who helped support us in our Zoom platform. So Allie, if you have any direction for the participants today, well, I would appreciate it.
Yeah, we just ask everybody that if you have a question, we have pre-muted your lines to cut down on background noise. Do either use the chat function or unmute your line to ask that question. Typically Becky and myself will try to act as moderators and keep an eye on that chat function. But if you would like to verbally ask a question, you will just need to unmute your line, which you can do by hovering your mouse over the screen, and depending on which view mode you're in, the options will pop up either at the top or bottom of the screen for you.
Great, thank you, Allie. So I'd like to introduce Madeline to you today. I know many of you are very familiar with her and the great work that she does there at the Hospital Association. But for those of you who do not know Madeline, Madeline serves as the Patient Safety and Quality Advisor with the Indiana Patient Safety Center at the Indiana Hospital Association. And her current role there includes assisting member hospitals across the state of Indiana with educational tools, culture of safety coaching, and support for harms prevention with a HIIN. She is a certified change agent and Lean Six Sigma Black Belt, so she's very well qualified in assisting you in your quality improvement needs. And Madeline is going to be sharing partnerships available. She's going to provide some highlights of the Indiana State Department of Health Strategic Plan and key data and resources available to address health equity in your organization. And again, the presentation today is in follow-up to the call convening meeting that was on October the 9th. So Madeline, I'll turn it over to you. And again, to the participants, feel free to chat in any questions that you have along the way, and we'll be glad to get those addressed for you.
Thank you, Becky, and good afternoon, everyone. Thank you for allowing me to take a couple of deep breaths this time and present this. For those of you who were at the convening, I gave you a little snippet of this presentation, and I'll be sharing it a little bit more detailed this time around. The focus today is really kind of introducing you to some opportunities for promoting health equity in your organizations, and kind of showing you how it links to some of our strategic partners, and how IHA can help you with this as well. And so this is kind of our kickoff that we just started promoting. I lead the health equity work, and I'm working with what I lovingly call Matt Browning, who is our Vice President of our Business Intelligence Department here, and he's the guy with all the data. And so when I had this big idea that we should be able to see organizations' support of health equity metrics, I said, Matt, can you get me some data? And so we put our heads together and we came up with some of the data and some tools to help you. But we're going to start off with just a couple of definitions, and that's actually to define health equity and health inequalities, and to kind of show and leverage on some of our partnerships that you may not be aware of right now, that are occurring across the state right now. And to kind of give you some power on how you can take a look at a snapshot of your data and make some choices on how you can increase your involvement in your community with your health equity measures. And then I'm going to share a bunch of different resources with you. So just to start off is really this picture sums it all up, and it's talking about what actually is a healthcare disparities definition. And as you can see with this picture, You know, equality is giving everybody the same tool or the same resource, but that doesn't necessarily mean that the tool or the resource that we give them, they are able to really use it. And so looking at health equity is digging in just a little bit deeper, and that's showing how we can work with each other to share those tools and resources, and two, what do we need to do to make those tools and resources work? And so, as you can see, in equality, everybody got the box to stand on, to be able to look over the fence to see the game going on. But equity is really, you know, taking a resource that maybe somebody doesn't need and sharing it with another, or taking that resource and making sure that it's modified enough so that it's able to be used. So very simple understanding there. When we think about health equity, most of the time we think about, you know, the very top four, which is race, ethnicity, language preference, and disability status. But, you know, we're really expanding on these equity measures as well now. So we're looking at gender identity, we're looking at sexual orientation, we're looking at veteran status, and we're looking at socioeconomic factors, which can play a huge role into how your resources are being used or what type of resources that you need. So let's first start off talking about some partnerships. So I want to take you back a little bit to 2015. It was then that CMS actually developed the equity plan for Medicare, and it had three bubbles that you'll see here. One is creating and sharing solutions. One is increasing understanding and awareness of disparities. But the bottom one is one that I think we all feel the big sting of right now, and that's accelerating the implementation of effective solutions. And so that is CMS's focus, which I kind of make a joke out of this, and I probably shouldn't, but I can't help myself. You know, CMS, you know, it seems like sometimes the information that we get, data sharing and things like that, it's kind of a little bit in the rears, and we're working so much more in real time. So I kind of have to chuckle to think that they use the word accelerating, because the ask of all of us is to get the ball rolling a little bit faster for these things. I do want to point out in my presentation, wherever you see a bright blue web address that's underlined, these are all the connections to the resources that I have posted here. So you received the PDF copy. So if you go to that copy and you go to those resources, you'll get some more information along with some of the points that I'm talking about today. So for those of you who are engaged with the HIIN work through HRET, you've probably also noticed that through the last 2 years of the project, we've really been tapping you on the shoulder for addressing these health equity metrics. We're looking at how are you collecting the data? How are you training your staff about collecting the data? Are you validating that data? Are you using it in any way for data stratification? Are you communicating it? Are you using it to address and resolve the gaps in care? And then looking at what is your culture? What is your culture like, and how does it support it? And CMS, through HRET, has mandated through the first 2 years plus of the HIIN project that we ask you to answer these questions every other month. So that kind of shows you how that word accelerating is important. You know, I know that, you know, I get asked a lot, well, Madeline, you know, we can't just change this, you know, in a month or two's time. This is a lot of work. And boy, I understand that it wasn't too long ago that I served in a role that you all are currently serving in my hospital organization. And, you know, it was me having to drive these changes as well. So, you know, that's kind of why, you know, I thought, what can we do to help hospitals out with this? Because a lot of hospitals aren't able to move these measures right now. there might be some competing priorities with it, or they just don't have the tools. And so that's what I'm here to help you with as well. So CMS focused on 6 high-impact priority areas, and that was based upon the review of a lot of your input, including these metrics that the HIIN participants had actually supplied the information for. And so they're really seeing a big snapshot of, hey, this isn't an easy thing for hospitals. And so they looked at this data and they broke it down into 6 high impact areas. And I'm not going to read each one of these, but if you can kind of scroll through, you will actually see that these impact areas mimic the metrics that I just showed you for the HIIN. So regardless of whether you're a HIIN participant or not, it is still a CMS priority, and we want everyone to be aware of that because we don't know what the future will hold as far as what will CMS's requirements be. It very well could evolve in the future that this could be another value-based metric that you'll be judged and held accountable for. So we really want to prepare you before that day ever comes. So once again, if you want to learn a little bit more about these CMS priority areas, go to the website that I've put at the bottom of this. So that's the big picture. Now, when we look at locally, ISDH has a strategic plan as well that introduces this very same concept. And I know that a lot of people may not be familiar with the ISDH Strategic Plan. If you've never seen it before, I ask that you go to the website and you take a look at it. It began in May of 2018 and it goes through December of 2020. So this is what Dr. Box's plan is for the state of Indiana and how we could meet many metrics across the state, but health equity is one of them. And so she points out in this plan how we need to develop and strengthen our partnerships to improve public health, and we need to make this data public and evident, and we need to make sure that we're meeting the needs of our communities. And so once again, this just feeds right into what CMS and is asking and what we've asked through the HIIN program and other programs as well. So in her plan, she has, as I said, there are different components to it with public health, but the two that stand out are the ones that I have starred here about ensure that the agency promotes and pursues health equity and minority wellness, and also reduce racial and ethnic disparities in infant mortality, which we all know Indiana has a problem with, and to strengthen the preconception health opportunities for women of childbearing age. So when you look, and you'll hear a little bit more about this as I continue on my conversation here, but when you look at these opportunities that are presented in these goals in the ISDH plan, this feeds right into the work and the beginning steps of how to get you the information that you need to meet these goals. So, did you know if you are a Joint Commission facility that the Joint Commission also promotes this? This is just a snapshot of the Speak Up campaign, the Know Your Rights brochure that the Joint Commission offers to all of the patients that come into your facilities as a Joint Commission regulated facilities. The verbiage right in this Speak Up campaign is, you have the right to care that is free from discrimination. This means you should not be treated differently because of all of these different categories that I spoke to before. And so, this is the public's information as well. So your public has the expectation as well that you're meeting their needs. So let's talk about engagement. So there is one organization out there that promotes equity of care. And so AHA has the 1, 2, 3 for Equity pledge that we have promoted at the State Hospital Association. Probably started about 4 years ago when we made this awareness to this. And the pictures right here are just showing you how many actual organizations from our hospital systems from each state have made this pledge that they are going to make equity a top priority in their hospitals. As you can see, Indiana has 26. So what that means is 25 hospitals in the state of Indiana, and the 26 is the Indiana Hospital Association, have all taken the equity pledge. We've got a long way to go, considering we have over 140 hospitals in our state that are eligible to take this pledge. And so I just wanted to introduce it once again, and I have the link on here, but just to kind of make you not be afraid of this, because I know a lot of people will say, well, what do I have to do if I take this pledge, or if our organization takes this pledge? Well, these are the actual 4 goals of the equity pledge. And if you look at it, they are the same 4 goals that I talked about with the HIIN work, and they fit right into the 6 strategic priorities of CMS. So if you are following any of those, you're already working on these equity goals. And hopefully, with some of the resources and tools that we can offer you, this will encourage you to do this as well. And so here is the website. This is what it looks like. It's not a rocket science thing, but it just says that your organization is choosing to support this equity pledge. And just to throw this in as a little side note as well, regulatory bodies are very receptive of this as well. So, you know, if you are putting together your portfolio for when you have your accrediting bodies present, make sure that you share this with them if you take this goal, because it is a big deal. It means a lot. So just something to look over and share it with your leadership in your organization. And there's a lot of resources and tools that you can get with the equityofcare.org website. So now I want to share a little bit with you what Matt Browning and I worked on, and that is, what does our data say? So just to give you a little bit of background before I show you this, the Indiana Hospital Association acts as the subcontractor for the Indiana State Department of Health in collecting all of your inpatient and outpatient discharge study claims information. So all of your organizations, doesn't matter whether you're participating in any certain programs, it's every hospital in the state of Indiana each month sends us your claims data. From that claims data, we are able to build reports, and we're able to abstract information, and that's how we can tell which codes are actually being used, and do we have equity codes being, you know, actually representative of what your claims and what your population that you're serving shows. And so I want to give you a little bit of background on how we know this data, and if it is all-inclusive, which yes, it is. So we know if we didn't have this data, we wouldn't be able to actually get a snapshot of your communities and helping to give you an understanding of what does your population look like. You know, not every patient that walks into your doors has the image of someone who may be struggling. I'm going to share some codes with you that what I'm talking about with struggles. And so these are called Z codes. So these Z codes, and this list has expanded even further since AHA put out this first list, but this is actually taking information from your patients and finding out what is occurring in their life that may be contributing to their healthcare needs. And so some of these you might not even think about. You know, I'm looking at problems related to upbringing in Z62. We're looking at problems related to certain psychosocial circumstances, occupational exposure to risk factors. These kind of items are not your typical codes that you're going to see when you're reviewing a claim from a patient, unless someone actually does an assessment, asks the question, and if your coders are aware of the fact that these codes can be collected. And so now I want to share with you a little bit, and then I'm going to go back a couple of steps. But this is what the analysis showed us when Matt ran a report on all of 2018's claims. So for our inpatients and statewide, we had about 780,000 claims. Of these claims, we had a little over 3,700 of them that had any Z code documented at all. So as you can see, that is less than 0.5% of our total claims had used any Z codes. And when you look down here at the list, you can see the number one is problems related to social environment, which could be housing and things like that. And then you kind of go down the list and you can match up these Z codes with the ones on the previous page that I showed you. But, you know, 3,800 claims out of 780,000 really is not a lot of claims. And so we had the aha moment of, wow, we have got some education to do, and hopefully taking this across the road to all of our hospitals across the state to say, this is what we're seeing, how can we help you start collecting more of this information so that we can then provide reports to you so you know what your population needs are. So one of the, for some of the hospitals that we've talked with already, we kind of did a little bit of analysis. So what are some of the obstacles? So one of them is definitely there is a lack of a standardized social determinant of health screening tool that's implemented in electronic health records. No surprise there with the different health records that we have, EHRs. You know, everybody has a different look. Sometimes, you know, you might have a new EHR, and if it wasn't built in already when you purchased the product, then your responsibility is, you know, how do you build that into your product? And there isn't one single tool that has been flagged as the one single standardized tool. Another obstacle is the reliance on the clinical provider staff to screen and document for these social determinants of health. So here is another concern. If it's not documented in the record, if you don't have your clinicians, your doctors, nurse practitioners, PAs, or whatever documenting it, then it kind of gets forgotten about. But one thing we do need to share with you all, when CMS started noting that, you know, we weren't getting a lot of this information, you know, it went back to the table, and actually the coding rule had changed so that a coder doesn't have to only, isn't required to code only off of the note from the physician or the PA or the NP, but if we have other clinicians who are documenting in that record, and most of the time this is what you see, if you have a case manager, if you have a social worker, if you have a dietitian, if you have a nurse, anybody who puts a note in the record about a conversation that they have had with a patient that really impacts this ability, you know, to collect this data. Or, you know, I think about dietitians and how many dietitians have conversations with patients about their diet. Maybe it's a new diabetic, and, you know, this all links back to our conversation that we had at the convening meeting about chronic diseases. you know, we see this a lot in this population, and I'll get to that a little bit more here coming up, but you can actually code for this off of another healthcare provider's documentation in the record. So hopefully that obstacle can be removed as we educate a little bit more for this. So just a couple more notes on developing Z-code reporting. You know, a lot of times we gain this information from the administrative claims, like I have noted on the first bullet point here. But, you know, there's also looking beyond the primary diagnosis and improving the documentation. So this is where you can pull in, if you have CDS teams or clinical documentation support teams, as they're having these, reviewing these records, you know, they might be able to do some more querying of the physician or any of the providers if they're reading into this record as well, and to get some of these things documented more. So when I tell you to expand your horizon for looking at these equitable assessments, this is what I'm talking about, how it extends beyond a physician, in between a physician and a coder. I mean, this is the whole healthcare team that can put this information in the record, and it can be used to collect this information. So opportunity. So when you think about this, this is where everybody goes, oh yeah, this is something that we're not going to be able to fix overnight or in a week or a couple of days. You know, I don't encourage you to go all in the beginning and try to look at health equity across all of your populations. But one area that is very specific, and I like to say this is a good place to start, those are your dual eligible beneficiaries. So those are your patients who qualify for both Medicare and Medicaid benefits. And those are usually pretty easily identified through your records. You can pull up records of who's the Medicare and Medicaid beneficiary. And the reason why I say this is a good focus is here's some information from a national sample. So of almost 2 million beneficiaries, over half of them experience social determinants of health. 33% were under the age of 65. So you know what that tells us. That means that they were not just Medicare beneficiaries. There was probably a disability associated with that. This is a key point for your hospitals. 64.8% of them are female, and they live in a rural region and are more likely to be a racial or ethnic minority. That's a huge number. And then another statistic that really jumped out at me was 55% live in a neighborhood where 20% of its residents live below the federal poverty level. So if you go on the State Department of Health website, or this might be information that you as critical access hospitals look at every day, you know what your poverty levels are, or if not, as I said, that information is available out there on the State Department of Health website. You can pretty much discern that 55% of these dual eligible probably live in these pockets of your neighborhood. So these are just some kind of statistics that kind of help support the dual eligible beneficiaries. And then expanding a little bit further, and this is what I said, kind of adding on to our chronic disease focus at the convening meeting, is these are the common chronic conditions that you see with these dual versus non-dual Medicare beneficiaries. So the light blue lines actually represent the dual, and the dark blue are the non-dual beneficiaries, which would just be Medicare. So as you can see, your dark blue lines, especially in the areas of hypertension, diabetes, rheumatoid arthritis, then you go into the depression, chronic kidney disease, all the way on down. Almost all of these chronic conditions have a higher classification for the dual eligible population than your single Medicare patients do. So this is why I think that just kind of starting with this population might be a good focus. So leading into that, I want to share with you some resources along with what IHA is starting to do some work on for as well. The first one is a really, really good toolkit from the Institute for Diversity and the American Hospital Association and the Equity of Care Organization. And this is a toolkit for eliminating healthcare disparities. It is a very simple, easy to use resource on how you can start to implement this process. And if you recall, I just said a couple minutes ago, there's not a standard source out there for doing this work, and this is what I mean. I'm going to share several with you right now. And because really, you know, I think until we start really getting an understanding about this, this disparate population, we're not going to be able to drill in on one sole tool. I mean, it's going to have to be what works best with your organization. So that's why I wanted to share several tools with you. Another one is the HRET Disparities Toolkit. It is also a very simple toolkit on how to begin collecting some of this data. Joint Commission has some great resources out there as well. They look at the LGBT community and has a great field guide for that, and also another roadmap for hospitals. So take a peek at these two toolkits as well. Another good one is a tool by Health Leads, and it's a social needs screening toolkit as well. And that leads me to some question and answer time right now. And so as I said, I really wanted to bring to your attention what does our state look like right now? And we have addressed the fact that we're really not collecting a lot of this data. 2, how can we help you? And 3, here's some resources to kind of get you started. And also, just to let you know that Matt and I are actually, you know, taking this out on the road as well. So as you kind of take this information, let it soak in, look over it, have further conversations. If you would like for us to come out to your hospitals and meet independently with your teams to help you get started on this, we would love to come, and we would be honored to come and help you in any way that we can, because we really not only want you to, you know, have a better connection with your communities, but, you know, we want you to be prepared as well. You know, should CMS come back and say, okay, guess what? You are now going to be required to report this information, and you know, we want you to be the star saying, well, we know that, and we've already got a plan in place. So I welcome any questions, or anybody have any other questions or asks or comments?
Madeline, this is Becky, and I had a couple of questions chatted to me.
Okay.
And I believe if you go back to the slide with the graph, with the different, yes, right there, one more forward, right there.
Oops. That one?
And I'm pretty sure this is the graph that they're referring to. Is, do you have this information by regions of Indiana? Thinking that there may be some of these, I think maybe some of these categories that are higher in some regions of Indiana than others?
You know, I can't say I have it on my hand, but I will say that I bet I can find it.
Okay.
Yes.
If you can, and you send that to me, why I will send that out to the group. The other question kind of leads into addressing some cultural types of issues, but do you have good resources or recommendations for cultural competency education modules?
So some of these resources that I shared include that as well. And so as I had said, these are the things that, why I put some different ones in here to look at. And I encourage people to take a look and see if some of these things fit in. Like this Health Leads has a really good tool in it as well. So what I have been telling people, and we have already done some hospital and safety coalition visits as well, is take a look at this. If you don't see that any of these meet, maybe perhaps your need as an individual hospital, let me do some increased digging to find exactly what it is. You know, every hospital has a different culture, and honestly, this is why I think there isn't a standardized tool. But every hospital has a little bit of a different culture. Every hospital has a little bit of a different need. And as you know, you all know, you know, you wear many hats in the critical access hospitals. So, you know, how can we meet that need? So take a look at these tools in here. If these don't seem to meet the need of your specific hospital, let me know and let me dig a little bit more. There's more toolkits out there than this, but these were the ones that I identified as the best.
Okay, great, great. Any other questions for Madeline at this point? And that's all that has been chatted to me, Madeline.
Okay. Well, as I said, you know what? I'm very easy to get a hold of. My information is in the presentation that you have, as well as Matt's. And, you know, you might want to look over some of these resources and shoot me an email if you have any questions. And then I will also get the information to Becky on the dual eligible in Indiana statistics and the chronic diseases.
Okay, great. I also shared in the chat link, or in the chat, the link to the AHA 123 for Health Equity Pledge. So it might be a nice time here at the end of the program to click in there and join. And again, want to thank all those hospitals that have already joined the effort. So thank you so much, Madeline, for sharing the information and kind of following up after our call convening meeting. Thanks to Allie with IRHA for supporting us today. We will be sending out the recording link to the program along with the presentation again. So please feel free to forward that link internally to share with others in your organization that may be interested in the information. And please send me any questions that you have. And I will connect with Madeline and Matt at the Indiana Hospital Association and get a response back to you. So have a wonderful day, everyone.